Itraconazole is a relatively common fungal infection endemic to the southwestern United States. Humans are infected through the inhalation of arthroconidia, or spores. While majority of infected patients remain asymptomatic, some go on to develop a pneumonia with cough, night sweats, fever, and weight loss, commonly referred to as valley fever. Less than 1% of these patients exhibit hematogenous dissemination to the soft tissues, bones, and joint spaces, earning the name desert rheumatism. Treatment is often not necessary, as it's a self-resolving disease in the majority of cases. However, some can experience persistence of symptoms and frequent relapses even after proper treatment. The case that I'll be presenting is an example of the latter. A 72-year-old female presented to the emergency department with new onset right knee pain and swelling. An X-ray and aspiration sample were inconclusive, suggesting pseudogout. An MRI was ordered, showing a suprapatellar effusion, as you can see in the top image. She was treated empirically, reported an improvement of symptoms, and discharged home. She returned a week later with worsening right knee pain, now limiting her physical activity. Another aspiration was obtained and sent for cultures, and she was prepped for surgical debridement of the joint space. Soft tissue samples were sent to pathology during the procedure, resembling the histological slide at the bottom of the screen. Both aspiration culture and soft tissue sample demonstrated a presence of Coccidioidomycosis. She was prescribed Fluconazole 400 mg once daily for 12 weeks, and her symptoms improved by follow-up. A year later, she returns to the ED with that same right knee pain and swelling. The knee was tapped and an MRI was ordered. Aspiration yielded cloudy synovial fluid with an increased white count, predominantly neutrophils, and growth of coccidioids. The MRI depicted in the middle of the screen demonstrates a large, persistent effusion with inflammatory changes secondary to infection. Antifungal therapy was transitioned from Fluconazole to Itraconazole, 200 mg BID for 12 weeks. She completed the course and has not had a relapse since. Before moving on to discussion, it is important to note that throughout the 2-year course of illness, she tested negative for coccidioids antibody not once, but 4 separate times, indicating a relatively poor sensitivity of the test. After reviewing the literature, I discovered that the presentation of the disease like so is in fact not uncommon in the Southwest. What did surprise many up here in Michigan was the fact that her only exposure to the pathogen was during a 3-hour layover in Southern California. Many patients experience relapse with or without treatment. The extrapulmonary symptoms make up the majority of the recurrences. Patients who are immunocompromised or have undergone previous bone or joint surgeries experience the greatest difficulty permanently resolving the infection. As of now, standard treatment for these patients is Fluconazole or Itraconazole for 12 weeks' time. Fluconazole has been deemed first-line therapy due to its easy oral availability, fewer drug interactions, and decreased risk of hypokalemia. Itraconazole has been shown to decompensate patients with congestive heart failure and should be avoided in these instances. Recently, a randomized, double-blind study was conducted involving 198 patients throughout 7 treatment centers in California, Arizona, and Texas. Their goal was to determine which, if either drug, was superior at treating non-meningeal progressive coccidioids infection and determining rates of relapse. After evaluation of patients 12 months later, 57% of patients responded positively to Fluconazole, and 72% of patients responded positively to Itraconazole in regards to resolution of symptoms. In determining relapse rates, though it was not statistically significant, patients in the Fluconazole group were more prone to relapse, 28% of them experiencing return of symptoms compared to 18% in the Itraconazole cohort. Both drugs were tolerated well without significant side effects. Let it be known that amphotericin B is effective as well, but reserved only for patients who fail both azole therapies. In coming to conclusion, I know this is not a disease we will see often in practice, but it is one that can be difficult to diagnose and quite resilient to treatment. If ever you come about such a case, I hope you can keep in mind what I've displayed today. If a patient fails Fluconazole therapy, swiftly transition them to Itraconazole. If a patient has no contraindications to the medication, consider Itraconazole first in monoarthritic septic arthritis. Thank you.